This talk is on shift efficiency and cognitive load reduction in the emergency department. So why does efficiency matter? The superficial answer would be metrics, right? Your job wants you to see a certain number of patients per hour and you want to keep them happy. I would argue, though, that there are more important reasons to work on your efficiency. The goal of this talk is to prove to you that by increasing your on-shift efficiency, you will lessen your cognitive load, which will result in improved on-shift learning, better throughput, which means happier patients, fewer medical errors, and less burnout. To start off with some background, cognitive load is the amount of mental effort needed to process information and complete a task. Basically, this is the mental energy that you're putting towards something. Cognitive load theory states that there are 3 types of cognitive load. The first is intrinsic, which is the complexity of the task at hand. A good way to think about this is you consider your 30-year-old female with right upper quadrant pain and a history of gallstones versus your 70-year-old male whose baseline GCS-10 with heart failure presenting with undifferentiated shock. Different amounts of mental effort will be required for each of these patients. The next type of cognitive load is extraneous, and this is the mental effort that's put towards things unrelated to the task at hand. These are the interruptions that we deal with every day in the emergency department. The last type of cognitive load is germane, and this is the effort that's put towards active learning, so the processing and integration of information into your long-term memory. As a brief refresher, there are 2 types of memory. The first is working memory, and this is very finite and transient. These are all the things that you can actively think about at once. The second type of memory is long-term memory, which has basically an unlimited capacity. So the goal of cognitive load theory is to maximize your germane cognitive load. And the reason for this is that retrieval of information from your long-term memory requires very minimal mental effort and does not take up very much of your working memory. So when you have more information stored in your long-term memory, you've effectively increased your cognitive load capacity. A good way to think about this is a cardiac arrest from when you were an intern versus as a PGY 3 or 4. As an intern, this is a very overwhelming situation. You're probably only involved in one aspect of care, whether that's running the code with ACLS or performing procedures like intubation or central line. As a third year, though, you've developed muscle memory that allows you to run ACLS without much mental effort and allows you to focus more on what caused the cardiac arrest and performing procedures. It's important to also think about the stress level that you have as an intern in PGY3. It's probably actually pretty similar on shift, but as a third year, you're handling much more. Your patient load is higher, your patients are more complex, and you're dealing with more interruptions. The reason for this is that you've stored up so much more long-term memory that your working memory is free for higher complexity patients. Because your working memory is finite, in order to optimize your germane cognitive load, you must manage your intrinsic and reduce your extraneous cognitive load. You might ask, what if we don't do this? What if we really just try to stretch our working memory to think about more things at once? And this can actually be pretty detrimental. Excessive cognitive load, as we all know, can cause psychological stress. We've all experienced that shift where we're overwhelmed, overstimulated, we're handling too many things at once, and this can often lead to medical errors. Another important part of this is that there's actually a physical stress associated with maximizing your cognitive load. They've done studies that show there is stress physiology when your cognitive load is higher. This includes dilated pupils, tachycardia, high blood pressure. This is important because it shows that there is a physical cost to having a higher cognitive load. And in a field like emergency medicine, where burnout rates can be so high, we really should be doing everything we can to minimize mental and physical stress. So to summarize what we've talked about so far, by reducing your cognitive load, you can improve your on-shift learning because you're dedicating more to your germane cognitive load. You'll have better throughput and happier patients because you can handle more complex patients and more volume at a time. You'll make fewer medical errors because you're not overstimulated and overwhelmed, and you'll have less burnout during your career. So the second half of this presentation is to discuss how we can improve our on-shift efficiency and how this will reduce cognitive load. Throughout this part of the presentation, anytime that there's something that will either decrease your intrinsic or your extraneous cognitive load, I've highlighted it in purple and pink, but I won't belabor these points too much, so keep an eye out. So we'll start off on receiving sign-out at the beginning of your shift. This is a very important topic because studies have shown there is high risk for error and miscommunication during this. So it's a very fragile part of our shift. To start off, you should always take notes while you're receiving sign-out. When we take notes, we don't want to take too many notes because if you're focused too much on the task at hand, you're not actually processing and integrating the information. But we should take some notes so that you're not relying on your memory for all of this information later. When you're receiving sign-out, you should always use the team before use clinical gestalt. And the reason for this is that they know the patient best. They can tell you why they ordered the test they did and what they think the disposition should be based on what they know. The caveat here is that you can use their clinical gestalt until you can't. Anytime there's an unexpected change in the clinical course, the most efficient thing to do is to start over. See the patient for yourself, assume nothing from the sign-out, because obviously they did not expect this to happen. And lastly, you should be using a sign-out room or an area where you can minimize interruptions during the sign-out process. All right, so you received your sign-out and now you're ready to pick up patients. This is an area that can be different for everybody, so I encourage you to figure out what works best for you. I'm going to tell you what works best for me, but take it with a grain of salt. I like to set the pace early, so I typically see 50% of my patients in the first 2 to 3 hours of shift. I hit the ground running and see as many as I can when I'm the least burdened by reevaluations and results that are coming back. I also like to batch patients, so I'll pick up 2 to 3 at the same time, see all of them, and then come back to my computer and put in orders. A pro tip that I learned during residency is to never look at the chief complaint. Obviously, you want to scroll the board and make sure you're not missing anything that should be seen immediately, but otherwise, I try not to read the triage note. The reason for this is that we all have a chief complaint that we don't want to see, and as soon as you see it as next on the board, you will be very tempted to think this is a great time to go get a snack or take a bathroom break. Save yourself the time, pick up the patient and look at the triage note afterwards, especially because the triage note isn't always accurate. Inevitably, a couple of hours into your shift, you're going to hit a lull in the number of patients that you're seeing because you have so many reassessments and labs coming back. I try to batch one reassessment with picking up one new patient. That way, during this time, I'm still seeing some, but not to the same extent as I was during the first few hours. Another important part of residency is to find your maximum safe capacity. This is the time that you have guidance and a safety net to fall back on, and so make sure you're utilizing that. Find out how many patients that you can see safely per hour, and then walk it back a little bit. All right, so now we're on to the patient encounter. First, you're going to chart review, and I like to do this before I see the patient. And while I do this, I verbalize my findings to my scribe or chart review it myself into the chart. The reason for this is that if you wait to do this later, you'll have to redo it. So as you're doing it, give the findings real time. The reason that I like to do this before seeing the patient is twofold. One, the patient's usually happier when you're familiar with their medical history, but two, you are undoubtedly going to have patients who are poor historians or like to tell a long story, and it's nice to have a roadmap so that you can guide them along and skip through the parts that may not be as important. Next is the history in the exam. Similar to the note-taking during sign-out, you want to minimize how much you're writing down to only the pertinent details. These are details that you want to remember that can change management, but you don't want to include more than that. Again, because if you're spending a lot of time writing the notes, you're not processing the information as well. Something that I've learned to be very helpful throughout my residency is interrupting myself while I take the history. And what I mean by this is that if you are seeing a patient, let's say their chief complaint is pleuritic chest pain, and you're hoping that you can perk the patient out, you should stop and ask those questions right then and there. The reason for this is you're never going to forget to go back to the main history, but you may forget to ask the perk questions if you wait till the end of the interview. This will prevent you from having to go back to bedside later for questions that you forgot. Next is to standardize your social history, and again, the reason for this is twofold. One, this reduces bias when you're interviewing patients, but it also helps because then you don't have to wonder later if you ask them about alcohol and drug use. Instead, if you've asked everybody, you know that you asked. Similarly, I like to standardize my physical exams. So every abdominal pain, I check for CVA tenderness, and every chest pain, I check for leg swelling. This way, when I have 5 chest pains and I'm going back later to write the notes, I don't have to wonder which ones I did a leg exam on. There are a few things that you should do before you leave the bedside. First is setting expectations. This is something that I've found to be super helpful to improve patient satisfaction. Especially in patients who have chronic medical complaints, I like to tell them early what my plan is. So starting off by saying, I don't think I'm going to resolve your pain completely today, or I'm not sure I'm going to diagnose what's been causing your chronic abdominal pain, but I have 3 main goals. I'd like to make your pain more tolerable, rule out any emergencies, and I'd like to help make sure you have the appropriate follow-up. Usually, when you set this expectation earlier, patients are a lot happier, and you can save yourself time of dealing with an unhappy patient later if you've set these from the start. You should also complete any anticipated consents and any procedures that you think you'll have to do. The best time to do anything is right now, and it's always going to take longer if you have to come back to bedside to do it later. So if you know you're going to give blood, or if you know you need to do staples on the LAC, try to complete those right then and there so that you don't have to interrupt yourself at a later time. And lastly, before you leave bedside, make sure you communicate the plan to the patient and the nurse. This should prevent the number of interruptions that you have later asking about what's going on or why the patient hasn't received an update. I like to say, hey, we're going to get a CAT scan and some labs. I'm going to order something for your pain. And once we have the results back, I'll come back to see how you're doing. If something changes in the meantime, let your nurse know and they'll communicate that to me. By the way, we need a urine sample, so if you have to go to the bathroom, do it in a cup. These are things that will save you extra time later if you outline this plan from the start. Remember that your nurses are disposition-oriented as well, so letting them know the rate-limiting steps will help improve efficiency in the department. Management in the ED should always be disposition-oriented. From the moment that you see a patient, you should know what your disposition is, assuming that every result comes back completely normal. If, despite all of the information you've obtained, you still don't know what the patient's disposition is going to be, this is a patient who deserves more of your attention. Whether it's through reevaluation, obtaining collateral, or doing more chart review, put in more time and figure out what you need to know in order to make that decision. You should avoid having any sort of wait-and-see plan because the time that you interview and examine the patient is when you know them best. The most important part of disposition-oriented management is anticipating barriers to discharge. Whether this is a PVR that needs to be obtained, pain control for the patient, or performing a lac repair, think about these things early and prepare as much as you can, because inevitably everything will come back right before you sign out, and then the rate-limiting step will be you. So you've seen your patient, you've put in orders. Before you pick up any new patients, you should run your list. I like to do this organized by length of stay, so first I'm focusing on patients who have been there the longest. As we all know, making it through a complete run of the list without interruptions is probably close to impossible, so every time you have a task that you can stop and address, you should do so. This could be completing the task, like a reevaluation, or writing it down for later, like a laceration repair. I like to keep a piece of paper on my table that has all of my non-urgent to-do list tasks. This means anything that I'm not currently the rate-limiting step, but eventually I will be. Now, these are some Epic-specific tips, but I like to use the provider comments for me and for the nursing staff to know the plan. Now, these are things that I've taken from other people and kind of created my own system. So in our provider comments, I use brackets if I have someone who's pending results. This means their workup's not complete and I'm still waiting for that blue box for more results to come in. I use 1 star if I'm about to be the rate-limiting step. This could be like a patient needs to receive medications and then I need to reevaluate, or a patient needs to be moved to a chair and then I need to discharge them. I use 2 stars when I am the rate-limiting step. So this patient needs a procedure by me, this patient needs a reevaluation, I'm the reason that this patient is still here, and I need to address that immediately. I also like to use the arrow to include my dispo plan. I usually like to say likely discharge or likely admit in case it gets communicated to the patient by nursing, but this is a good way for me to remember which chest pain did I want cardiology to see and which one was low risk and can go home. This prevents me from having to repeat the cognitive processing that I already completed. Here's an example of what my list may look like on any given shift. Other little tips for anyone using Epic, there is a blue square box that lets you know when new results come in. I love to use this when my list is very long especially, so I would encourage you to become familiar with this if you're not already using it. Next is if you're interpreting your own EKGs and chest x-rays, this is something that you should write down in real time. Very similar to chart review, you don't want to have to do it twice, so as you're doing it, verbalize it to your scribe or include it in your note. Another thing that I think is really important that we often forget, when you're reading imaging and there's an incidental finding of a thyroid nodule or an adrenal cyst, take the time right that second to include it in your impressions. You're never going to remember who had the thyroid nodule at the end of your shift, so do it while the information is fresh. Here's an example of what those blue boxes look like and using them to your advantage so that you know which results you're still waiting for. So you've run your list, completed tasks, and before you're picking up new patients, you should write your H&P. You're going to be more efficient when it's fresh in your head. Just take the minute to write it down. Obviously, if a sick patient comes in, that can inhibit you, but this should always be something that you're keeping up with. Answer your secure chats. This is a really important one that many physicians don't like to participate in. Secure chat was invented because not everything needs to be an in-person interruption, and it's trying to reduce your extraneous cognitive load. The unfortunate thing is that if we don't answer our secure chats, each interruption is going to be doubled. They're going to send a chat, and then you're going to get an in-person interruption as well. So take the time, answer your secure chats before you pick up new patients, and make sure you're not missing any pertinent information that's been sent through a chat. You should also make sure you've reviewed all new results. You shouldn't have any of those blue boxes there, because if there are, it means that someone may be ready for a disposition. And lastly, you should disposition your patients. If you have everything back and you can make the disposition, this should always be your priority, and you should write the MDM as you go. If a patient got admitted, before they fall off your list, take the time to write your MDM because that's when everything is the most fresh. If you've just filled out their discharge paperwork, write their MDM. All right, so you've made it through shift, you're in your power hour, what should we do now? The most important thing is to identify possible discharges and the rate-limiting steps. So which patients do you think may get discharged in the next hour? This could be the patient with the CT head that's done but not yet read and you expect them to go home, or the patient who received a migraine cocktail and you think will be ready for reevaluation before sign out. If there are patients that you think may be ready for discharge, then you should identify the rate-limiting steps. Are we waiting for their urine? Do we need to ambulate them? Did we interrogate their pacemaker? Try to identify these very early in your power hour so that you have time to intervene on them. If you have patients who you think will be ready for discharge, like that CT head, prep everything so that it's ready. That way, as soon as the CT head gets read, which probably will happen 2 minutes before sign out, all you have to do is click the discharge button. During this hour, you should also be reevaluating any sick patients and any patients with an uncertain disposition. That way, when you go to sign out, you have the most up-to-date information and you can give them your best recommendations. If you have a Kaiser patient and you haven't talked to them yet, make sure you do that. That way they get the story from the primary history taker and you can give them all of the information and let them know what's still pending. This takes the load off of the team that you're signing out to, which is a super important start to their shift. Make sure that you update your patients during power hour. So if you have a patient that you're admitting to medicine for an AKI, let them know that that's the case so that it doesn't fall onto the next team who's never met them. This is also a time to catch up on MDMs if you've taken care of everything else. And then lastly, perform your procedures. If you've been waiting on the lac repair, go get that done. If you have a diagnostic paracentesis, whatever it may be, try to do this now so that you don't have to stay after your shift. So lastly, we're going to talk about giving sign out, and this is a very important part of your shift because it's the accumulation of an entire shift's cognitive load, and so it's really important that it's not only comprehensive, but that it's efficient as well. IPASS is a structured sign-out format that was created for inpatient services. Studies have shown that this has improved communication and reduced errors. ED-PASS is an adapted version for the emergency department. You'll start with the severity of the patient. Is this patient sick or not sick? Next, you want to give the disposition. Are they getting admitted? Are they already admitted? Are they pending a consult? After that, you can give the story and follow with to-do list items. You always want to end by giving contingency plans so that the team knows what you thought based on your initial evaluation. This is like what we talked about earlier, that you know the patient best. You want to pass on your clinical gestalt so that they don't have to do the same legwork that you did. Next, you want to minimize unnecessary words. Try to avoid telling stories about the patient or including anything that contributes to their cognitive load but does not contribute to management of the patient. If you have a patient who has been given discharge papers and is maybe pending transportation, try to give a one-liner because you never know what could happen and they should at least have an idea of why this patient was here. So now that we've discussed strategies for being efficient on shift, let's talk about some of the barriers. We all know that interruptions are a very real part of emergency medicine, with studies showing that you're interrupted every 4 to 6 minutes, and some studies saying it's even more frequent than that. So interruptions are going to happen, and we probably can't do much about that, but we can minimize their impact. The first way to do this is to reduce the number. Set the plan early with the patient and the nurse so they don't have to come back with more questions later. Also, make sure you're leading by example. Try not to interrupt other people who are mid-task, and try to use secure chat when you don't need to ask something in person. Next would be modifying the type of interruption. Again, this brings us back to keeping up with your secure chat, but also using verbal orders when you can. This will prevent you from having the reminder later to put in an order that you said that you would. The last tip for this is to limit the impact on your well-being. When you're mid-task and an interruption presents itself, if it's not life-threatening, it's okay to finish your task or at least part of the task before addressing the new interruption. This could mean you finish signing your orders before you take the EKG, or finishing the conversation with the patient before you go to the overhead for a consultant who's on the phone. These are simple ways to make it a little bit less exasperating when you're frequently interrupted on shift. Okay, so now that we've talked about all of the ways to be fast and efficient on shift, let's talk about the times that you should really slow down. The most important is when you're discharging a patient. Anytime that you're discharging, you should review all of the labs and imaging to make sure you didn't miss anything earlier. So another time that we really need to slow down in emergency medicine is when we have a patient that doesn't fit a schema. One of the most important parts of emergency medicine is pattern recognition. So we see enough abdominal pains and we know which ones are serious and which ones are probably not that serious. The important thing is noticing something that's a little bit off from the norm. When something doesn't totally fit into a schema of an unimpressive abdominal pain, we should slow way down and figure out why. Why is this case specifically giving you pause, and how can we address that? You should never be forcing a patient to fit into a schema that you already have. If it doesn't fit, there's a reason why. We should always spend a little bit more time on a patient with abnormal vital signs, especially a tachycardia that we can't explain. Another time that is really important to slow down, and this is more for patient satisfaction and preventing interruptions later, is when you don't think that they need a workup. If you have a patient who has runny nose and cough and chest pain and body aches and they're 25 and healthy and you think it's the flu, take the time to listen to all of their symptoms, to explain to them why you think that this is probably nothing serious and why we don't need to check labs today. This will save you more time later and allow the patient to understand why they're not getting the same tests as everybody else. And then obviously, when a patient has an unclear disposition, like we talked about earlier, or a sign out who has a change in clinical course, those are times you should step back and say, are we missing something here, and what other tests should we order? So to summarize, why does efficiency matter? By increasing your on-shift efficiency through all of those ways, you can reduce your cognitive load. This allows for better learning on shift, which allows you to be more efficient in the future, leading to happier patients, less burnout, and fewer medical errors. Thank you for watching. Hopefully some of these tips help you on your next ED shift. Cool.